Good afternoon. This is Dr. Jim Waller. I'm a retired colorectal surgeon. I practiced both with Ohio Valley Colorectal Surgery and most recently have been sort of an administrative assistant to Dr. Santiago Arruffat at Evansville Colorectal Surgery. I wanted to take some time today to talk with you about Dr. Arruffat. My experiences with him, both as a young surgeon and as someone who has now been in practice for almost 20 years in the Evansville area. Dr. Arruffat first came to work with us back in, I believe, 2006, right out of his colorectal residency training. And he took the place of Dr. Randall Christosek, who had retired a year or so earlier. Um, just to give you some background, I finished my colorectal training in 1986. We were doing no laparoscopic or robotic surgery at that particular point in time, and in fact, robotic surgery had not yet been developed. I had done some laparoscopic training both over at St. Louis University as well as down in Atlanta, and found that our instrumentation at that time and then the procedures that we were attempting were not very compatible. It took much longer to do the case laparoscopically, and not that people who are not familiar with surgery would know this, but we ended up making an incision that was about as long as my hand, which is about the size of an incision if we were doing what would be called an open surgery, say on someone who had a disease which required part of the colon to be removed. So when Dr. Arruffat came to practice with us, uh, he was quite efficient at doing laparoscopic surgery, as by the early 2000s, laparoscopic surgery had literally exploded onto the scene in colorectal surgery and was becoming the procedure of choice in those people where it could be used. Dr. Arruffat basically trained me in how to do laparoscopic surgery, certainly by the standards that were in place in the early 2000s. I would scrub with him on all of his cases, and then on my cases he would scrub with me. And to be honest with you, was doing most of the case to begin with, because there's quite a learning curve when one develops new techniques, particularly going to laparoscopic surgery, which I always compared to the oh the what you might go through if you went from doing an aerial view of streets versus doing a street level view. And that's one of the things that makes it difficult to adapt to the new procedure, because you're right on top of your operative site if you're doing a laparoscopic or robotic approach, as opposed to doing, as I would say, the aerial view of the operative site when you're doing an open procedure. So, that being said, I was beginning to get very proficient with laparoscopic surgery, and Dr. Arafat and I had teamed up on a very difficult case that involved a patient who had diverticulitis. Diverticulitis can be a particularly difficult disease to deal with due to the inflammation that is associated with someone who has had chronic diverticulitis. During the case, we accidentally got into an iliac artery. And you might wonder how this happens, but when we're doing a diverticulitis case, quite often the piece of inflamed colon is lying in the pelvis and is lying on top of the major blood vessels that take blood to the legs. So we made a small inadvertent incision or tear in the iliac artery as a result of trying to move the colon off of the artery, as it was stuck quite tenaciously to the iliac artery. So once we had done this, we had to convert from a laparoscopic case to an open case, and it didn't take us very long, probably less than a minute, to open the abdominal wound so that we could do an open approach and get our hands in the abdomen. We had really very little blood loss. We had anesthesia helping us to make sure that the patient remained absolutely stable during the procedure. I then went ahead and did what we would call an open resection of that piece of colon and an anastomosis where we put it back together. And that really didn't take me more than probably about 10 minutes or so. But during that time, Dr. Arruffat is standing with his finger on the dike, so to speak, preventing any loss of blood through the iliac artery. And the iliac artery is pretty good size, larger than my index finger, as it is carrying quite a bit of blood down to the leg, and in this case it would be down to the left leg. So once I had done the resection of the colon, we had completed what we really had set out to do for this lady. He then set about repairing the artery. Now, working in the pelvis is like working in a funnel, and it's a little bit tedious. You get your hands into an awkward position, and people who have worked on engines or done any kind of work where you put yourself in a difficult mechanical position can understand this. So he was using a very fine plastic suture, type of suture we call Prolene. It was probably what we would say a 5.0 or 6.0 Prolene, which is very fine. I don't have enough hair to show you, but can be as fine as the hair on your head. So it was going to be a bit of a tedious procedure to close the artery. So he starts throwing his stitches, and he would throw a stitch, pull it up, and we would use a running type of stitch for this, kind of what we call a baseball stitch. And so he would throw a stitch, put his finger back over the artery, and our surgical tech would then suction any blood that had spilled during that throw. So this took him probably longer to complete than it did me to take out the piece of colon. And again, very tedious. When you're doing this, your hands get crampy, your eyes are tired. Anyway, he gets to virtually the last suture that he was going to have to throw, and as the tech reached down with her suction tip, she hit his hand and broke the suture. Many physicians, many people, period, doing something like this would have come unglued. Dr. Arruffat simply reached over, patted her on the arm, and said, "That's okay, we'll do it again." I knew at that point that we had made the right decision on a surgeon to join our practice. And Dr. Arruffat has exemplified this type of behavior ever since he's been in practice. In fact, I can say that I always had a lot of pride in all of the surgeons in our practice, because everyone that practiced for us, and it happened to be 4 men at this time, were all gentlemen in the operating room and treated their operating room personnel with respect. We always enjoyed operating. We had fun operating, and I know it sounds counterintuitive to imagine that you've got a surgeon and maybe an assistant surgeon and techs, and you can be having fun, enjoying what you're doing, and yet be serious at the same time. But in fact, it was my experience that we did a better job, we were more efficient, we got the case done much more quickly and safely when everyone was calm and kept their cool. So I wanted to share this with you. Dr. Arruffat, I don't think, knows that I'm doing this, but I thought I'll sit down and tell this story about Dr. Arruffat, how he trained me to become a very good laparoscopic surgeon by the time that I retired, and how I decided that he would be my physician going forward, because I placed that much trust in him. So I hope you enjoyed the story. Hope it wasn't too long-winded. Thank you for listening, and should you need any colorectal surgery services, do not hesitate to give Evansville Colorectal Surgery a call. I'm going to look at the office number now, because I don't remember it off the top of my head, but the office number is 812-999-ECRS, and that would be 3277. So 812-999-3277. And I thank you for listening.